right, so for the next half hour, we're going to talk about all you ever wanted to know, and maybe some you already do know about C1 and C2 and the surgical anatomy of this area. So this region in a difficult to access area for surgeons, more or less, kind of hiding, tucked up underneath the skull base. Lots of high-priced real estate, including vertebral arteries, Batson's plexus, the confluence of all the sinuses and intradural sinuses, brainstem, you name it, you've got it in the cranial cervical region. And hence, a lot of surgeons are a little shy about doing anything too invasive here. Surgical approaches, trauma, all rely on a good working knowledge of this area. The embryology is fairly straightforward with wink and nod. It's actually very complicated at the cranial cervical junction, but to distill that into a few little brief sentences, we all remember that third week of gestation, you have these three layers around the developing embryo, and the important component of those layers that gives rise to bony structures, and those bony structures induced via the notochord, the neural structures in the area induced by the notochord. And of that, the mesoderm, and more importantly, the paraxial mesoderm, the one to focus on, will give rise to somites, these little blocks of mesoderm that go up and down. And then those somites will develop into the typical sclerotome, dermatome, and myotome. For the somites, remember, this induction process is going on at about the same time they're developing. So this shows you the notochord as its ascent up through the dens, the clivus at the basion, skipping an area here at the cranial cervical junction, and hence the reason chordomas, for example, are found in this region in some patients. For C1 and C2, the key for that development is the proatlas, and the proatlas is essentially the fourth occipital block of somite, or the sclerotome here. So this being the third, and this nice color coding between embryologic development and adult development shows you nicely that the proatlas has lots to do with especially the very inferior aspects of the occipital bone, the occipital condyle. But we see also that it has some contribution to the apex of the dens, the lateral mass of C1, a little bit of the posterior arch of C1 as well. And then the first block of somite, this first C1 segment, gives rise to C2's middle portion, and then C2 will contribute to the remaining portions. C1, as far as fusion sites, has these three usual sites that you'll especially see if you're looking at lots of CT images of children. Additionally, you can have some accessory fusion sites, so especially in the anterior arch of C1, there can be more than this single typical fusion site, so that shouldn't be confused with something that's pathologic or a fracture. C1's relationship to the skull in general, as you can see from this fetal specimen, is very small. So the reason that the head of a child can come off, can sublux very easily, just due to that difference between the size of the cranium above and the smallness of C1 below. If we look at a superior view of C1, we see some typical features. This has a bilobed nature of the superior articular facet. This is a more typical disjointed articular facet. We'll see the smaller anterior arch that's going to have more cortical bone associated with it versus the posterior arch that'll have more of a internal trabecular structure that I'll show you in an upcoming slide. Importantly for posterior approaches, the vertebral artery groove, which is here. This is the midline, so the posterior tubercle of C1, and that groove where the artery bubbles over into the medial aspect of your approaches is usually about 20 millimeters. So you have about 2 centimeters here to work with before you'd encounter the vertebral artery, and first encounter the more medial vertebral venous plexus. Transverse foramina that we see through all of the cervical vertebrae, but typically the vertebral artery only enters C6, right? Not using C7, which the vertebral veins do use. This shows you the cortical construction with an axial section through C1. And as I told you, the anterior arch having more cortical bone. The posterior arch has a mixture. Lateral masses are mostly trabecular, and then we see trabecular bone extending out into the transverse processes. An example of the relationship of the vertebral artery within the vertebral artery groove, and this is extended out more medial than it should be, but a deep groove here. Occasionally this groove is covered over by some of the posterior atlanto-occipital membrane, which can ossify and form an arcuate bridge. A posterior ponticle, as some people refer to it, as I'll show you an example of. And then we're seeing the backside of the facet for the dens, which is just here. Lots of morphometrics that can be performed on the atlas, surgical morphometrics that are important to spine surgeons, being the angulation of how you get the pedicle screw into the so-called pedicle, which is, there's not a pedicle here more or less, but into the lateral masses without going medially into the vertebral canal or laterally into bad things as well. This is a good example of an arcuate foramen, so a little foramen created here over the vertebral artery, and you can see that.
Sorry, can you go back one slide?
Yep.
And I don't know if you're going to say this later, but what, like, in your mind, is the ideal angle for the C1 lateral mass, medial lateral angle?
That's a great question. You know, everyone carries different numbers. You know, the 1530 is what most people, you know, carry in their mind, I think, nowadays. But that changes person to person, and everybody's variable. Nobody's carrying around the same exact C1. I think that's the take-home message, that every person's different, and trying to force numbers on a bone without looking at the variation can be a problem. Hey, Ehud, how are you? Good. Thank you. Thank you.
Is it all cortical, or is there some nerve? In a sense, we always issue bicortical versus.
Yeah, there's a extremely thin cortical margin, but it's mostly trabecular bone. Yeah.
So when it comes to fixation, you prefer to put in bicortical.
Yeah, definitely. Definitely. Thank you. So sometimes this little bony bridge can give you the sense of safety as if you're doing a midline approach to C1 and your cautery is going down and marching over laterally on the posterior arch, and you're like, oh, there's no vertebral artery or plexus there, and there's this little bony bridge, and just on the other side is something very bad, which is the vertebral artery. And left and right vertebral arteries supplying 1/3 of the blood supply to the brain. That could be a traumatic event. Other variations you see of C1, this is a normal bifid posterior arch, not to be confused with a fracture, but surgically that's important. If you're going down midline with your hot cautery turned up to 40 and you don't recognize that there's that little separation, you can go right into the dura, and I've seen CSF leaks caused with that. You can have other variations between the lateral aspects of C1, the lateral masses, the transverse processes. These are not that uncommon, paramastoid processes that extend down from just medial to the mastoid process and attach and form a pseudofacet with the lateral mass or the transverse process of C1. They come lots of varieties. This is very common atlanto-occipital fusion, and that can be picked up easily with flexion extension films, just plain radiographs. And this is very commonly associated with a bifid posterior arch, which you could step off into the foramen magnum very easily during dissection. Odontoid process has more. We have 6 ossification centers here. The apical segment will fuse last. One of the first to fuse is this midline segment that people forget about on board exams, etc., so that the actual odontoid here has 2 segments, ossification centers. If you look in the literature and you ask our esteemed faculty what they call these different parts of odontoid, you hear everything. This is a catch-all area. So, for example, the area that drives me crazy is the area here at where the transverse ligament comes around the odontoid, and it gets called the waist, the neck, the stem, the base, the isthmus. Depends who you're talking to. So obviously lots of confusion that comes around. Some people will throw in the shoulder more laterally for this area. They'll call the base here more anteriorly. So an area in desperate need for agreed upon international terminology. Odontoid process, which now formally in international terminology is the DENS. You're not supposed to say odontoid process anymore. So odontoid fractures is a thing of the past, right? Also called the peg, the shaft, has lots of trabecular bone in it, as this 3D CT image shows. A very thin cortical region, so putting fixation in here, there's a lot of loose, very thin trabecular bone. Ossification centers also have lots of different terminologies associated with them, and we should not forget the ossification center here that fuses last for the apex down to the remaining portion of the odontoid. And then the subdental synchondrosis that people forget about, but very important when we're talking about type 2 odontoid fractures, can persist into adulthood in a large number of people. So this is not just a synchondrosis that we see in adolescence and childhood. There's a nice depiction of an adult, this is an elderly adult 3D CT showing the synchondrosis at the arrow. The morphometrics of C2 have been well described, and some of this has little bearing on surgical anatomy. Some of the surgical anatomy of importance is where do you put your pedicle screw, and even the terminology here is strange. So if you think about what different people call different things, is there a pars interarticularis for C2? Is there an actual pedicle of C2? Some of that's debatable. So a pars area would be seen just here with this aerial view. So yes, a pars, and that the screw initially is a pars screw, and the pedicle is actually this small little bony bridge connecting the body of C2 over to the lateral mass. So it's an extremely small little area that may or may not actually get much screw insertion. This is a dissection that we did that shows that nicely. So here's the left side of C2, the lamina transverse process, and we've removed the superior articular facet, right? We just shaved that off with a micro drill, and look how small this little pedicle is. So that area, if you're coming out here with your initial sight through the pars, has to make its way through this tiny little area, mostly trabecular bone with thin cortical areas to reach up into the odontoid. One has to also be careful of this. So who knows what this is? This little area with the lower area, lower arrow is the impression of the upper segment, this knuckle of the vertebral artery. So it's called the artery, the cave of the vertebral artery. You can see as we've drilled out the superior articular facet how the pedicle screw advances into this very termination part of the pedicle. Cortical bone here, lateral to the transverse foramen, and vertebral artery foramen in the transverse process, and that artery can imprint here just medially. So this screw, most likely, if the artery had been in place, would have at least touched the artery. Some structures that one may also see, a basivertebral foramen, and this is a site for, just like all the other vertebrae that we have venous structures traveling into the body, but you have one here, and we just showed in an anatomical study that that site marks the internal aspect of where the synchondrosis would be at that level. So various vertebral artery caves, as I just mentioned, some that are very shallow, some that are extremely deep. So this is something to be considered when you're putting a big sharp screw into the pedicle, that you're probably going to touch that or at least get inside its cave. And we recently classified the different varieties of cave, which go from almost nothing to significant, with a large knuckle that extends right up into the pedicle, making it extremely small and shallow. Inferior view of C2, you can see the basivertebral foramen here. This also illustrates the inferior facet, and we see a vertebral artery cave, that this would be a moderately sized cave. All right, the articulation between C2 and C1, we have two synovial joints in the midline, so one with the anterior part of the dens with the anterior arch of C1, but also remember that the transverse ligament is here, and it's also forming a synovial joint at that location. There can be some articulation with a piece of extension of the anterior arch of C1 here called the coronal cave. We also see that laterally we have our two facet joints. Ossiculum terminale, a common finding, is not a fracture, congenital malformation, and typically those things will kind of be hanging or suspended within the apical ligament as it runs from the apex of the dens to the basion. Os odontoideum, commonly seen in pediatric clinics, and looks like that. Lots of ways to fix that, as our esteemed faculty will give you some ideas of during our course this weekend. Some oddities that you don't see so often. We can have a bifid odontoid that looks like that. We can also have a Klippel-Feil anomaly that involves the odontoid process. Ligaments, it takes strong ligaments. Some of the strongest ligaments in your body exist at the junction between your head and C1 and C2. And just to give you a perusal, we have a textbook that's coming out that's devoted to these ligaments. So that's something that you might reference in the future. But coming from a posterior view, and this approach is not compatible with life, so don't put this in your surgical database. This is posterior approach. The cord, brainstem have been extricated. We have taken the extension cephalad of the posterior longitudinal ligament, which continues as our tectorial membrane, to fan out along the clivus, and that's been reflected. And once you do that, you come to the heavy hitters. And the heavy hitters, as far as stabilization, transverse ligament, right, which is this horizontal portion of the cruciate ligament. This inferior and superior cruce have minor roles. Next in line, the alar ligaments. We just did a 4-part series on the detailed anatomy and biomechanics of the alar ligaments that is coming out soon in World Neurosurgery, so you can learn all you want to know about those shortly. This is a deeper component of the tectorial membrane, which we've identified in the past as being an accessory axial atlantal, which is what it's called in the textbooks, but actually this ligament extends all the way up to the occipital bone in most specimens, so little suspenders and a belt ligament. Alar ligaments, which are always misillustrated in textbooks as being this almost vertical structure. These structures, if you see them, and we can show them to you in the lab, are almost horizontal in their configuration. Limit axial rotation and keep the head from being distracted off of C1. Apical ligament has really no bearing on cranial cervical stability. Most textbooks will say that it's a remnant of the notochord, and we just proved in a recent research that there are absolutely no notochord cells in apical ligaments, of adults at least. Then you have these so-called accessory ligaments that are the smaller players, but they're there for a reason. Most of them you can't see on MRI, but we have transverse occipital ligaments, which we're not sure what it does. It connects each condyle on the side and may have a little tiny connection to the apex of the dens. Again, it's there for a reason, but we're not smart enough yet to know what it does. We have real oddities. Barkos ligament. Who's heard of Barkos ligament before? Anyone? Most people have not, but it runs between the occipital condyles and runs anterior to the tip of the den. So maybe a suspension belt of some sort, an additional layer for keeping the anterior odontoid from moving forward. Who knows? Anteriorly, again, this is hopefully not a surgical approach you'd ever do, but lateral occipital ligament from C1 transverse process up near the jugular fossa. Lots of bad things around that ligament, so hopefully you'll never see it. And then finally, some very small ligaments that we've defined in the past with anatomical studies. Little band that runs between the front of the odontoid, and I'm saying odontoid instead of dens, to the anterior arch of C1, so the anterior atlantodental ligament, an accessory ligament of the cranial cervical junction. This is a nutshell of importance factors for these ligaments. Transverse ligament obviously is the strongest. Capsular ligaments people forget about, but these are also equally important. So taking off the capsule with surgical dissection is not a good idea if you can get away from doing that. Alar ligaments, this is comparable to our findings recently. They're about 200 newtons, and then the others have smaller amounts of contribution. In our lab dissection that I'm going to show you later, we're going to see an actual dissection of the cranial cervical junction from behind. So I'll go through these a little more quickly, but this is a posterior approach, Inian. You can palpate C1, C2, all the way down to C7. And the trapezius has been flipped laterally. That's the first muscular layer that you'll go through with an approach posteriorly. This is the next layer, the splenius capitis, right, attaching to the mastoid, one of the three muscles that attach to the mastoid process, and runs medially, having this attachment into the nuchal ligament. At this view, you can also start to see the emergence of the greater occipital nerve, the dorsal ramus of C2, and that'll run up on the occiput and runs just medial on the occiput to the occipital artery stemming from the external carotid artery. We move splenius capitis muscles back, and the next layer we see is this very robust semispinalis capitis. This attaches up along the superior nuchal line. We see at the inion nuchal ligament. We see the emergence of the C2 dorsal ramus, greater occipital nerve. We see the third occipital nerve from C3. And then important landmark muscle, especially for folks doing retromastoid approaches. This is the longissimus capitis that runs up, attaches just medial to the mastoid process. And surgically, it's a great landmark because one of two things are going to happen. If you're out this laterally, if you're doing a far lateral approach, for example, between the splenius capitis and the longissimus capitis, you're going to find most commonly the occipital artery. So if you're trying to do a bypass procedure, you want to make sure you don't ding that vessel there. But as this picture shows, it can also run deep to the longissimus capitis. So this corridor laterally between splenius and longissimus is important for identifying the vessel, unless you're just going to bipolar it anyway. Suboccipital triangle, this is the deepest layer, and generally I understand we don't, in surgical approaches, see this view. This gets all cut away with the monopolar and pulled out laterally with the cerebellar retractor, etc. But it's good to remember that if you palpate C1, this is the posterior arch, posterior tubercle, the only muscle, posterior arch, the only muscle attaching here is this posterior capus, posterior rectus capitis, minor, it's a mouthful. C2, however, has some stronger muscles, the rectus capitis posterior major, the inferior oblique, and a hint of the superior oblique. And it's that little triangular area, suboccipital triangle, that's where you find bad things, right? So that's where the vertebral artery lives on top of the posterior arch of C1. You can also use that inferior oblique muscle as a landmark. So just below that is where you'll see the emergence of C2. So I see the residents and fellows often when they're doing their dissection laterally with the cautery, they just buzz through and don't pay attention. So they're always cutting greater occipital nerve or injuring it with the cautery. So it's good to at least know it's there, and you can push it over with the retractor instead of just transecting it. Muscles of the front that help hold C1 to C2 include the tiny, small, little, almost clinically inconsequential muscles, the rectus capitis anterior, rectus capitis lateralis. Hopefully you should never be in that area. You will, however, with approaches to the anterior cervical spine, at least more inferiorly, and hopefully you've all seen longissimus coli, or longus coli, longus capitis. Coli comes down from the third thoracic vertebra, ascends up, and you can see ends on the anterior tubercle of C1. Capitis runs from C6, right, carotid tubercle that marks the entrance of most people's vertebral artery into the transverse foramen at that level, and then extends all the way up to the base of the skull. And what important nerve runs on top of the longissimus capitis that you should try to avoid with ACDF procedures in this area? Sympathetic trunk, right? So the sympathetic trunk is here. A lot of residents that I've talked to, they for some reason believe it's on the longus coli, but it's actually over the longus capitis. Lots of venous structures. We highlighted the vertebral artery, but Batson's plexus is just as prominent here as it is anywhere else along the spine. And in fact, we've shown in a recent study all of the intricate connections between the intradural venous sinuses and Batson's plexus at the C1, C2 junction. So there are big veins on the front, inside, and back of the C1, C2 junction, and those will be coupled with not only the intracranial venous sinuses, but also the vertebral venous plexus, and additionally, just anterior here, we would see the anterior vertebral venous system that's running up in this area as well. And finally, deep cervical vein. If you've ever done a deep dissection along C2, you've probably encountered this and tried to bipolar it as quickly as possible. It runs in the gutter between the semispinalis cervicis and the lateral aspect of the lamina of C2. Some structures that can be very proud and prominent in the area. This is the suboccipital venous plexus, and this shows you how engorged this can be. So lots of bipolar cautery all over the suboccipital triangle, all over the midline to maintain hemostasis. One important surgical variation is that pica, posterior inferior cerebellar artery, in not an insignificant number of folks can come off the vertebral artery extradurally here just over C1 and then enter inside to the posterior circulation. For lack of time, we're going to skip through vertebral artery. You can have lots of vertebral artery and persistence of fetal circulations that we'll not get into. Vertebral artery regarding C1 and C2 anatomy is very significant, especially the V3 segment here along the vertebral artery groove. We'll skip through that. Lots of important branches. We have, for example, posterior meningeal vessels that you'll see just before the vertebral artery enters inside the intracranium. Those can be coagulated, but you have to make sure it's not a posterior inferior cerebellar artery that's coming off. Those are usually bigger and can coexist. So sometimes it's questionable whether to take anything that's coming off of this V3 segment of the vertebral artery. One that you can take off is the muscular branch, or Salmon's artery, the suboccipital artery. Lots of anastomoses in this area, so you'll see branches going to the facet joints, running medially to go and become segmental radicular arteries, medullary arteries, branches that go off laterally into muscle. I mentioned the pica variant. An arcade, Dr. Iwanaga, one of our research anatomists here, is working on this now and dissecting out all these fine vessels that travel up around and form this periodontoid plexus. So blood supply in this region is important and comes from various locations. Occipital artery, it comes from the vertebral arteries primarily. We also get some ascending pharyngeal branches, so branches from the external carotid, branches from the subclavian, you name it, they're going to supply this area. Lymph nodes in the area, the retropharyngeal nodes are the primary drainage spot for the cranial-cervical junction, especially C1, C2. This is important with Grissel syndrome, where you have inflammatory lesions around C1, C2. You can get atlantoaxial subluxation, and it's thought to be due to retropharyngeal abscesses or retropharyngeal infections that engorge these lymphatics and result in the subluxation. Nerves in the area, I touched on briefly. I'll show you these more specifically in our lab demo a little bit later. But the important nerves to remember in this area for C1, remember that pinched between C1 and C2 is the dorsal root ganglion of C2. And remember that its dorsal ramus will become or is our greater occipital nerve that has both muscular and cutaneous components. Our suboccipital nerve is clinically inconsequential. It runs between the posterior arch of C1 and the vertebral artery, supplies the suboccipital muscles, and the semispinalis capitis, can be taken with impunity. Importantly, the ventral ramus of C2 courses laterally and will usually not be seen so much, but courses just lateral to the vertebral artery. So if you go chasing this ventral ramus, which is going forward to contribute to the cervical plexus, you're in danger of injuring vertebral artery. We also see C3, the dorsal ramus of C3, and its medial branch being this third occipital nerve, which most people with their cautery will injure during a midline approach through the nuchal ligament at the cranial cervical junction. Seeing those same structures from left to right, greater occipital nerve as it emerges 3 centimeters lateral to the inion, the third occipital nerve, and then on the right, the more inconsequential suboccipital nerve. Accessory nerve is also located in this area, and we see very vividly that as you start to approach the cranial cervical junction, you'll see the dentate ligaments if you're doing an intradural dissection, and dorsal to those dentate ligaments, you're supposed to be safe with just dorsal rootlets that are sensory in nature. This is some of the C2 dorsal rootlets, but also remember that the accessory nerve comes from the upper 5 cervical segments, runs posterior to the dentate ligament, so you don't want to go injuring that with dissections. This is the suboccipital nerve, vertebral artery, which is anterior to this highest dentate ligament at the foramen magnum. We'll skip that. Accessory nerve, biomechanics, complicated. You can look at this slide a little bit later on. That's a smattering of some of the major motions that occur here. We'll skip through those for lack of time. Depending where you go, you'll be forced to learn, you know, the Wackenheim's line, McGregor's line, everything you can think of. And some of these have utility, some less utility in the age of MRI and CT. Powers ratio, very useful ratio to carry around in your bag of tricks, and this is very good for pointing out axial and occipital instability. Okay, that's a smattering of some of the more detailed parts of the surgical anatomy of C1, C2. So we'll show you some more of that with our videos from the lab a little bit later on, and hopefully we all learned at least one thing from that. So thank you.